You're juggling it all: work, family, decisions, expectations, 6 hats, maybe more every single day. But behind the scenes, your body is running on stress, and stress left unchecked will lead to illness. I'm Dr. Shami, an integrated family doctor, and this is 6 Hats, the podcast that helps you understand what stress is doing to your body and what you can do about it now. Hello, everyone. Welcome back to the 6 Hats podcast, where we explore the many roles women carry and how stress, lifestyle, and physiology shape our health. Now, today we're diving into something incredibly common, yet often misunderstood, and that's shoulder pain. So if you've ever struggled to lift your arm, sleep on your side, or even reach into the back seat of your car, this episode is for you. So I'm joined by Steffan Cavalera from Kaiser here in Melbourne, and we're unpacking rotator cuff injuries, what they really are, why they happen, and most importantly, how to actually heal them. Welcome, Steffan.
Hello, Dr. Shami. Thanks for having me on again.
Amazing. So I have to say, patients, I've really loved your previous podcast, and it was so warming to my heart to hear that patients listened to it, went to see a physiotherapist at Kaiser, and got better for hip pain. So that's amazing.
Oh, that's incredible. Yeah, thank you so much.
This is a wonderful resource. So we had to have you back. And this time round, we're talking about shoulder pain. So it's one of the most common complaints, musculoskeletal complaints, especially as we age. Yet many people don't fully understand what's driving it. So I'd love for you to start. What stories do people tell you when they come and see you with shoulder pain?
Yeah, so often it is this slow build of symptoms. There's not one insidious incident or one particular incident that set it off. Obviously, we can see shoulder injuries that are acute in nature, but often for the people 40 and 50 plus years old, it's happening gradually over a period of time. And they'll say, oh, it started hurting, as you mentioned before, reaching into the back of the car, lying on the side, reaching to the top shelf, and progressively gets worse over time.
Oh, wow. And when you say gradual, are we talking months or even longer?
It can be. There's so many different things that affect the shoulder. So if someone's taken on a new task, a new role at work, or even a new role around the home where they're moving, lifting more, it can happen quite quickly. But often where I'll see people and it'll be a little bit of a problem a few months to go, enough for them to kind of ignore it for a short period of time. And then over a couple of months, it gets worse and worse to the point where they feel like they need to catch up with a doctor or a physio.
Amazing. So let's dive deeper. So we want to talk about rotator cuff, but I'd love for you to explain it in a really simple way for our listeners. What exactly is the rotator cuff?
Well, it's probably best to draw back to the shoulder joint itself. So a shoulder joint is really freely movable, different to the hip where we've got a strong ligamentous structure and it's pretty rigid. The shoulder, we can reach up behind our back, out to the side. So it sacrifices a bit of structural stability for that freedom of movement. So rather than relying really heavily on the joint capsule and the ligaments for stability, it also relies heavily on the rotator cuff muscles, which are a group of 4 muscles that wrap around from the shoulder blade to the true shoulder joint.
Right. And why is this group of muscles so important for everyday movement? It's literally what you've said, isn't it? Because you can move it in so many different directions.
Yeah, correct. I mean, it works along with muscles through the upper back and even to the side of the neck to help with our posture in everyday life. But yeah, especially when we're reaching out of our base of support. So it allows us, we have that freedom of movement and it allows us to do so with still some element of stability.
Amazing. Amazing. Now, what are the early warning signs people tend to brush off?
Yeah, it tends to be pain reaching above 90 degrees. So often, reaching up for something in the kitchen or even driving for a period of time can set off pain. One of the most common ones is sleeping on the affected side. So if it's your right side, sleeping on your right side during the night, you wake up feeling pretty sore, and that progressively gets worse to the point where you can't lie for very often on the affected side. Sometimes it's more subtle. Sometimes, it's people reporting that they get pain sitting at the desk whilst they're working or whilst they're holding an iPad or reading a book.
Excellent. That comes on to my next question. How much does posture and desk work contribute to this kind of pain?
Yeah, so there's some research that says posture can be a predicting factor for rotator cuff pathology, but there's often not really sound research there. Some people can have poor posture and no rotator cuff related pain. But for most people I see, there is often a correlation. So they might be rounded through their upper back slightly, their shoulders are slightly rounded, or they're doing tasks that cause them to reach out in front of them a lot. It might be household tasks in the kitchen, or as I said before, being at the desk. So although it's not set in stone that if you have bad posture, you're very likely going to have rotator cuff pathology, it's often what I would see clinically.
And you mentioned something about sleeping and sleeping on the side. So why does shoulder pain often show up at night and when lying on that side?
Yeah, so the most commonly injured rotator cuff muscle and tendon is the supraspinatus. The supraspinatus attaches at the back, the top back of the shoulder blade, and then it travels through this space to go to the front of the shoulder, the head of the humerus. And it travels through this space called the subacromial space. So we think of the tendon being at the bottom like the floor, and then the roof of that space being the subacromial bursa. And a bursa is a fluid-filled sac. We have them all around our body, around our joints, and they're often in really close location or touching our tendons, and they look to help reduce friction with movement. So if we have an issue at the tendon, it's torn, it's thickened potentially, that can irritate the bursa, and then the outer wall of the bursa thickens and becomes inflamed. So when we close that space, either when we reach up towards the ceiling or when we lay on the side and we compress that space, the bursa can be a source of pain.
Amazing. Thank you, Stefan. So, when patients come to see you and they're bringing scans and it shows tears, how much should they worry?
Well, it's pretty common to get asymptomatic tears. So research has shown that prevalence of rotator cuff pathology in people over the age of 50 is 50% and above in that category. But you might have half of those people that are asymptomatic. So we're really looking at, does what shows up on a scan relate to that person's dysfunction and symptoms? So if they've got a minor tear and their symptoms don't quite match up with that pain reaching above head or out to the side, it's probably something we don't need to worry too much about. We might want to do some prevention training of strengthening through the tendon. But if the imaging matches up with what they're complaining about in everyday life, then yes, we're looking at trying to rehab that. And if it's a significant tear, then it's going to take a significant effort to rehab and get back to normal function.
And this is a good time to actually go through the different type of reports you might get because, you may go and see a GP and a scan is requested and the scan result may come back with a partial or full tear. So I'd love to know what the difference is between tendinopathy, a partial tear and a full tear.
Yeah, so a partial tear can be less than 1 centimeter to 3 centimeters in width. A full thickness tear is 3 to 5 centimeters. Some people hear full thickness and think, oh gosh, it's completely ruptured. That's not a ruptured tendon. Above a 5 centimeter tear, you can have a massive tear, which is 6+ centimeters. And then a rupture would be a complete dissociation. So we're not touching one end to the other. So if it's a rupture, more than likely you're going to need surgical repair. But with those partial and full thickness tears, a lot of them can be rehabbed. And if we're not repairing the tear through rehab, we're at least strengthening the healthy tendon around it. Now, when it comes to tendinopathy versus tear, so tendinopathy is a chronic condition affecting the cells of the tendon. So it often involves micro tears rather than one really large gross tear. And there's changes that happen to the cellular structure of the tendon, and inflammation is often present there. So you can have a thickening of the tendon with micro tears in tendinopathy, or you might have one specific partial thickness or full thickness tear. alongside the tendinopathy and the tear is often that thickening of the bursa. So that's often what I'll hear in the report. The most common imaging we'll see for this is ultrasound because it's really quick, easy, cost effective. It's good for the superficial tissues. It's not so good for ruling in or ruling out other pathologies at the shoulder. So if we're worried about something more sinister, something going on within the shoulder joint itself, we'd really want to get an MRI, and that would differentiate between intra-articular within the shoulder joint or rotator cuff and other structures around, the front of the shoulder. But yeah, most commonly it's that supraspinatus tear with thickening of the subacromial bursa.
And that's so reassuring to hear, Stefan, because often when you think full thickness, you think, oh no, you need to see a surgeon, you need surgery. But you've actually explained that really well. It's so reassuring. So if someone is listening right now with shoulder pain, where should they start?
I think it's always really good to get in touch with a physio and your GP. So the GP might provide some advice and some pain medication and assess whether it is something that needs to be scanned or something that you can go straight to a physio for. I'm really selfish as a physio. I love seeing the shoulders first because I can differentiate pretty quickly within an assessment whether this needs imaging or whether we can use a series of special tests and strength and mobility tests to come to a diagnosis and form a bit of a prognosis.
Oh, that's really helpful. So GP plus hopefully physio as well, and making that as a priority. But I love to know, let's go down the whole pathway of rehab. What does that look like? So when they come and see you, what does that journey look like?
Yeah. Well, it's interesting you said, GP and physio, in that often I'll see people who might have only seen a GP in the past, and kind of the band-aid fix is to get a corticosteroid injection into that subacromial bursa that's thickened and irritated, which can be really good for symptom relief in the short term, but it's unlikely to resolve the underlying issue, which is pathology at the tendon, weakness at the tendon. So I think the GP is great for helping with the management side of things. But for anyone that comes through the door with rotator cuff pathology, I really have to convince them that they have to commit to a rehab program. And if it's a minor issue, it might be 6 to 12 weeks of a rehab program. If it's a significant issue, it can be 3 to 6 months or 6+ months ongoing with a management strategy. So yeah, I think being mindful to start with rehab and then probably use the more medical side of things if rehab is failing initially.
That's really good to know as well. Because, when, in today's world, we want quick fixes, but sometimes we've just got to slow that pace down and realize it's that consistency of turning up, doing the exercises, and it can take 6 months or more. So it's a bit of a wake-up call, isn't it, Stefan?
Yeah, it's tricky. I'm the same. Whenever I've had an injury, I want it better the next week.
Yes.
And often our rehab exercises are not fun, but the carrot at the end of the stick is we want to get your shoulder better so you can throw your ball with the dog, so you can do your everyday tasks, so you can tolerate driving or sitting at the desk for long periods of time. So that's often what I'm trying to sell to people, to try and get them to commit to doing their shoulder exercises. There's also an element of it might be the doorway to start strengthening in general, which if we look at the population we see often with rotator cuff pathology, 50 plus, that is part of the long-term picture. If we want to improve their posture, if we want to make sure they're not rounded and kyphotic, which means slightly bent through their upper back, we want to try and strengthen all their postural muscles. So this doesn't become a reoccurring theme of, we have a tendon that's irritated, it has a tear, bursa becomes irritable, we get an injection, do 6 weeks of rehab, but then 12 months later, we're in the same boat again. So it can be hopefully if it's a minor issue, it can be a bit of a blessing in disguise to get moving and get strengthening.
Excellent. So before we leave you, Stefan, what are the biggest mistakes you see people make when trying to fix their shoulder?
Yeah, probably what I mentioned before, getting the injection, feeling better short term, and not committing to a rehab program. So there's even a study that looked at people who got corticosteroid injections versus who didn't with rotator cuff or subacromial bursitis and rotator cuff pathology. And initially, the injection-based group did better, but over a 2-year period, they did worse because they're getting that quick Band-Aid fix without committing to the rehab. Whereas the longer term changes of addressing whatever the factors are causing injury, whether it's a weakness in the tendon, whether it's postural issues, whether it's behavioral issues, how much time they're spending at the desk or doing a task that causes them to round at the shoulders. So you can combine both, but I think it's a real risk just to do the injection side of things and not to do the rehab. So I think that's the first major thing I think of with rotator cuff pain and where it goes wrong, where I tend to see people 3 or 4 years down the track and they've said, oh, I've gotten injections in the past, it got better, but keeps coming back every 6 to 12 months. The other side of things is people don't rehab it long enough. So again, there's challenges to rehab. For some people, it's not fun. It can even be a little bit painful at times, especially in the early period. And it's the time commitment. So often I'll see people who have done rehab maybe for 6 weeks, but then they've dropped off their exercises. They've gotten to the stage where they can reach their arm out to the side without pain, but they haven't built up their function to a level where they can meet the demands of their everyday life. So if they're throwing a ball repeatedly to their dog, we need to get them strong enough to be able to do that with confidence. If they're spending long periods of time at the computer, then we want to strengthen their shoulder and their upper back muscles to hold them in the right position to tolerate being at the computer for long periods of time. So I think, both resorting just to the injection alone or doing rehab for a short period of time always results in people not getting the full recovery complete and often then having a reoccurrence, as I said, 6 or 12 months later.
It's so true, because I was just thinking of commitment, but also that motivation to keep going. And perhaps that's where seeing a physio can really help, the accountability, rather than trying to stay motivated for such a long time. I think we can, it's such a normal way to lose interest after a while. But you've given some really important information. Just got to keep going. Otherwise, things might relapse even a year or 2 later. Would that be right, Steffan?
Yeah, and that's why if we can build your rehab into a broader physical activity routine, so a strengthening routine, I think it's more achievable long term. So it's different for an athlete who's going to stick to their rehab because they really want to play sport on the weekend or go for a run. I think general population have more or less clear goals. They don't need to be playing a game in 6 months' time. They just want the pain to go away as soon as possible. So if the pain goes away short term, it's often enough for people to say, well, I've done my job. I don't need to do it anymore. Whereas if we're thinking about long term, protecting the health of the rotator cuff tendons and also just protecting that person's general function and well-being, if it can be part of a broader strength training routine and it's 2 exercises twice a week, part of a bigger routine that's maybe 10 or a dozen exercises, I think it becomes more achievable. And again, it can be maybe a blessing in disguise to start addressing, general strength and factors that happen with aging, such as muscle loss and, changes in posture, which are pretty common, maybe not so much at 50, but 60, 70 years old, where you see people shrink a little bit, round a bit more. So I think they're all things that you look to improve on long term and mix in the rehab with that.
Amazing. Thank you so much for your time today, Steffan. It's actually given me so many insights into shoulder pain that I actually didn't even think about. So this is awesome, but it's also so hopeful that, even if you do have discomfort, the scan may show with a tear, there is a solution, which I love.
Thank you, Shami.
Fantastic. Thank you. Thanks for listening to 6 Hats, where it's all about progress, not perfection. If this episode spoke to you, don't wait, hit follow now, leave a quick review, and share it with someone who needs to hear it. Want to take your next step today? Download my ebook. The link is waiting in the show notes. And remember, this is general advice only. Always speak to your practitioner for anything medical. See you next time.